Okay, welcome everybody. Today we're going to discuss the use of shockwave intravascular lithotripsy in non-surgery on-site centers for the treatment of calcified coronary lesions. I'm really excited about our conversation and the presentations today. We have a fantastic group of faculty. I am Alex Truesdale. I am a member of the Interventional Cardiology Leadership Council in the American College of Cardiology, and also co-director of the Cardiogenic Shock Service at Inova Heart and Vascular Institute in Northern Virginia. Should also mention that I work out of 5 cath labs, and on some days I'm in a center that has VAD and transplant, and on some days I'm in a center that has 1 cath lab with a balloon pump and limited options. So I think that'll sort of flavor our conversation. So my co-faculty members are Dr. Poonam Velagapudi. She is an assistant professor at the University of Nebraska Medical Center. She's the associate program director for the Cardiovascular Medicine Fellowship, also at the University of Nebraska. And she is co-author, most importantly, for today, of the 2022 update of the SCI Expert Consensus Statement on Percutaneous Coronary Intervention without on-site surgical backup. We also have with us today Dr. Clay Sizemore, an interventional cardiologist in a very busy institute. He's part of the Cardiovascular Consultants of South Georgia, works out of a non-surgery on-site center, and really delivers high volume expert care to the community, along with his partner, Mr. Chris Newman, who's the Vice President of Clinical Services at Archbold Medical Center. So I think we're going to get a lot of great perspectives from everybody today. We're going to talk a little bit about what the 2022 updates say about the use of calcium modifying devices within non-surgical facilities, a little bit about what is shockwave intravascular lithotripsy, what is its place in the algorithm, and what is the evidence for management of calcified coronary lesions, and a lot about real world applications and experience, both on the medical level, the patient level, and at the administrative level. So really looking forward to this. And without further ado, I will pass the microphone off to Dr. Velagapudi.
Thank you, Alex, for that invitation. I will go ahead and give you a quick rundown on our update on PCI with non-surgical facilities that was recently published. So I'm not going to go in every single detail, but in 2014, there were all these important things that were mentioned about facility requirements. But the important thing that I want to bring to light is this patient and lesion characteristics that are unsuitable for these non-emergency procedures. So we all know the patient characteristics that are high risk, and we do avoid them. But what about the high risk lesions? So the 2014 guidelines asked all these lesions to be excluded: upper unprotected left main, diffuse disease, extremely angulated lesions, more than moderate calcium, and inability to protect major side branches, degenerated older vein grafts, these lot of thrombi containing lesions, and if there was an anticipated need for rotational atherectomy or cutting balloon or lasers. So how often do we see these? At least in my practice, I don't see a type A lesion anymore. More than 75% of our cases are now sort of very calcified and with all these descriptions. So it's very hard to exclude these lesions from getting PCI in centers without surgical backup. So the lesion complexity is increasing, but also there's a lot of reasons why patients are being turned down for surgery, and patient preferences are also important to keep in mind. If patient wants to get a PCI or a percutaneous revascularization, that is something that we need to consider. But also we're treating left main disease, more multivessel disease because of these reasons. There's lower complication rates, and the NCDR and VA data, really show that the complication rates are less than 1%, even close to 0.5% perforation rates, and about 1.5% vascular complications. These have been steady without increasing, and so we know that the procedure has become more safer in more experienced hands. And moreover, more programs have all their HUT teams, and they have their quality reviews, and they improve techniques, and the equipment that we have these days have lowered these complication rates. Now, there is data, both global versus US, may not be randomized trials, it's just two randomized trials, which I will touch upon. But there's a lot of observational data and retrospective data, both from US as well as other countries like UK, Dutch, Japan, Australia, Canada, showing the safety of performing these PCIs in a non-surgical facilities. Now, increase in PCI within ambulatory surgical centers has happened because 2020 CMS coverage also approved those, and operators are performing these in an increased number. There's also the operator legal risk. By that, what I mean is if we exclude all these complex lesions in a guideline document, and then if an operator has to perform one of these at a non-surgical facility, and if something were to go wrong, then there's a lot of legal risk involved as well. And so that's something that to keep in mind in the background. And these have been steady without increasing. And so we know that the procedure has become more safer in more experienced hands. And moreover, more programs have all their HUD teams, and they have their quality reviews, and they improve techniques, and the equipment that we have these days have lowered these complication rates. Now, there is data, both global versus US, may not be randomized trials, it's just two randomized trials, which I will touch upon. But there's a lot of observational data and retrospective data, both from US as well as other countries like UK, Dutch, Japan, Australia, Canada, showing the safety of performing these PCIs in a non-surgical facilities. Now, increase in PCI within ambulatory surgical centers has happened because 2020 CMS coverage also approved those, and operators are performing these in an increased number. There's also the operator legal risk. By that, what I mean is if we exclude all these complex lesions in a guideline document, and then if an operator has to perform one of these at a non-surgical facility, and if something were to go wrong, then there's a lot of legal risk involved as well. And so that's something that to keep in mind in the background. Now, I really want to focus on calcified lesions because these are the most common lesions that we see on a daily basis. Now, in the 2014 guidelines, as I just mentioned, more than moderate calcification or the need for atherectomy devices were a no-no for these labs. So the randomized trials that I just talked about are the CPORT-E trial and MASCOM trial. So they compared the PCI at surgical versus non-surgical facilities. And what we see is the CPORT trial results here. There was no difference in the death at 6 weeks between the two centers. The same thing at 9-month outcomes, really no difference. There was this PCIs at non-surgical centers were non-inferior to the PCI at surgical facilities. Now, there's also several observational trials showing the safety in higher complex lesions such as upper left main disease. Though there's no comparative group, there was low incidence of complications or need for emergent cardiac surgery and transfers, which was around about 0.01 to about 2%, 3%. So it's not at all high. And then there's data lacking, again, comparative data, but there is some data showing that atherectomy can be performed safely with lower complication rates, and some have also shown that CTUs can be performed with about 80% success rate. So the highlights of the 2022 updates kind of takes all these into account, and we talk a lot about all the various important things that centers need to have to perform these procedures when they do not have surgical backup. So all these ASCs, OBLs, and hospitals without surgical backup have been defined, and we can go through that in a little bit here. Now, transfer agreements are very, very important because, sometimes the receiving facilities may not find it very useful to take these patients who are in high complication, and, their rates of mortality may be higher. So this is the reason why centers should always have this pre-agreement with hospitals about transferring these patients within 30 minutes and have ambulances and other necessary things, for example, mechanical support, or they should have space enough to accommodate all these for patient transfers. Operator requirements is a very important thing. I think we covered the importance of having an experienced operator who can treat complications, who has some experience And we did mention that early career operators should probably be mentored by somebody who's more experienced before doing independent cases at such facilities. And staff requirements, I cannot reiterate enough how important this is. Your staff has to be well trained. They need to know how to look at hemodynamics, for example, or use, your MCS devices, and they really need to be trained to do these procedures and know what and how to react when they see something that's important. Now, surgical consultation, it's not, all these cases should not be done ad hoc. We recommend that these cases where there's intermediate or high syntax scores be discussed with a physician, with a surgeon. It could be a weekly meeting or some sort of a consultation so that patients get the appropriate recommended revascularization strategy. Case selection and management, we included a lot of expanded indications as compared to the 2014 guidelines, and I'll go through those in a second here. And these are the patients that should be avoided in freestanding ambulatory locations. So judicious case selection by the operators is really important. And anybody who looks at these would know that these are high risk patients who may need more support, or if something were to go wrong, then they need more really higher level of supports. So this is the operator experience that is mentioned in the document for a new interventional cardiologist, experienced and very experienced. So we recommend that the docs who do these cases in non-surgical facilities should be at least experienced, over 3 to 10 years of experience, and competent to use the atherectomy devices with some experience with STEMI and shock. And they should be able to practice in a cardiac, or may have had some prior practice in cardiac surgery facility and are familiar with the surgical perspective. So this is the flow chart. So you start off with a patient with a planned cath or PCI with an experienced interventional cardiology. If it's a last remaining vessel, or if it's a retrograde epicardial CTO, and patient is a surgical candidate, then they should go to a PCI with surgery on site. If the answer is no, then we look at other high risk things that we just talked about, like decreased ejection fraction. And if you're thinking about planned atherectomy, left main CTOs, degenerated grafts, then make sure they do go to centers with either surgery, or if they didn't have surgery, they should be a level 2 with like your ECMO, PVAD support, and calcium modification devices and things like that. If the answer to that is no, then look at their other patient comorbidities. Are they high vascular complication risk, transfusion risk, AKI risk, baseline respiratory risk? Then they, if the answer is yes, then they would still go to a hospital without surgery on. They can go to a hospital without surgery on site, but they should have at least a level 1, so respiratory care, blood bank, vascular surgery services, and things of that sort. And if the answer to everything on the left side is no, then they can be done at an OBL or ASC facility. Now, these are how facilities are classified. Level 1, without surgery on site, have low volume, are usually low volume, less than 200 PCIs a year. And then level 2 is a little bit more higher level, where they have a 24/7 ICU, anesthesia, radiology support, and they're well-staffed and well-resourced, whereas the cardiac surgery facility will obviously have on-call cardiac surgeon, perfusionist, and shock team. So the difference would be that the level 1 and ASC OBLs, we usually have a balloon pump. And then the next level would be level 2, where you have your impellers, ECMOs, and then finally the highest level where you have transplants and LVADs, and you can put the patient on cardiopulmonary bypass anytime, 24/7. So what I want to highlight here is that the first, on your left hand side, the ASC OBLs and level 1s, we recommended using either a cutting balloon or IVL, and the rotational atherectomy and orbital atherectomy are reserved for our level 2 hospitals without surgery, or the facilities with surgery. And the reason for that is, the complication rates. If a complication were to occur, then it's easier. You need this required support, which the ASC and OBLs and the level 1 centers would probably not have. If there was a large perforation, or if you have to get a patient on a PVAD, then it's really, those are not available in your left-hand side. So we recommend IVL across all groups, because we have good data to show that the complication rates are so low that really it's just a balloon that passes. And if the balloon passes, then, the most I've seen is having a dissection. So we have recommended IVL along all categories. And so in short, just as a practicing interventional cardiologist, and all of you also have seen that I'm noticing that the complexity of the CAD that we treat has increased, but the procedure-related complications has gone down. And we're having a lot of national data that we can compare ourselves to and improve ourselves, which has really helped in this. And PCI at these facilities without surgical backup are safe, without an increased need for emergent cardiac surgery. The 2022 guidance for PCI at facilities without surgery have expanded the lesion subsets, so you can treat more of these disease high-risk cases. The IVL use has been recommended across all facility types, and this is because of the high success rate, which is greater than 90% in all the trials that we've seen, and low complication rates in the management of these calcified lesions. And above everything, I think I cannot stress on the importance of the operator decision-making or the HOT team when making judicious decisions for our patients to discuss and kind of select the right patients for the right kind of setting. So I think this plays a really important role. And with that, I want to thank you all and pass it on to Alex Truesdell for the next talk.
I'm going to discuss now just a basic overview introduction to intravascular lithotripsy technology and its use in coronary calcified lesions. So what are some of the issues with calcified coronary lesions? Increases safety risk, as you can see here in the cartoon, often impedes stent deliverability. And even if you are able to deliver a stent, it can often prevent full stent expansion. Lithotripsy for cardiovascular applications is a technology that has been well established in non-coronary areas and non-cardiac areas in the past. I think it's clear that there's been many decades of safety data, and it's really a really great innovation to now leverage this for use in coronary arteries. Here's some of the basic components. I think when you're really just breaking this down into the most simple components, it's a balloon, which we're all familiar with, and the delivery system, which we're all familiar with, and then that just plugs in via connector cable to the generator. So really not that much different than a lot of equipment that we're already familiar with in the cath lab. So what are some very key primary advantages of coronary intravascular lithotripsy? So number one, no requirement for specialized wire. You can use your workhorse wire and carry on with the case. You also have modification of the deep wall calcium in addition to the superficial wall calcium. So that's also another really good advantage. You don't really have the distal embolization risk that you may have with other technologies. And you're just doing a 4 and then 6 atmosphere low pressure inflation. So, some of the risks that are involved when you're taking balloons up to 14, 16, 18, 20, 24 atmospheres, where you're now risking fracture, dissection, rupture, really go away with this technology to a large degree. There's also ability to protect the side branch. You don't have to remove the side branch wire as you often do with other calcium modification techniques. And it has a very short learning curve. Again, wire balloon technology. So what is some of the data? The data is exhaustive and I'm not going to go through it all. But what you can see here is it's been really well studied. There's quite a number of publications in the literature, over 150 with over 2,000 published patient outcomes. And some of the highlights is that it is an excellent safety profile compared to the other devices on the market, and a very high effectiveness and efficacy data as well. One thing that is near and dear to my heart is intracoronary imaging. And I think in conjunction with any use of intravascular lithotripsy, it really has to be paired and partnered with intracoronary imaging. So you can assess, what is the calcium angle? What is the calcium thickness specific to OCT? Or even with IVUS, what is the length of calcium? What is the, do you have a 270-degree arc? And that's going to help you decide what are the lesions that I need to modify, what is the appropriate balloon sizing of the reference vessel, and how do I know I achieved appropriate effect before moving on to stenting. So I'm just going to present a very simple case, and I'm actually presenting a non-complicated case for a reason. So this is a patient in their 70s with hypertension, hyperlipidemia, chronic kidney disease, elevated BMI, mild LV dysfunction, coronary artery disease that had prior circumflex intervention that is admitted with a non-ST elevation myocardial infarction. And this patient identified to have multivessel coronary artery disease involving the proximal LAD and the mid-left circumflex coronary artery, both of which have calcified lesions. And again, this is one of those things that's not terribly technically complex, but we have radial access, we have multivessel disease, calcified disease. In a lot of cases, this might have given some folks some pause. Do I treat this on the spot? Do I need to transfer? And here, I think our options are, very easy with the presence of intravascular lithotripsy. So you already have your workhorse wire down, some preparatory work with a compliant balloon. I definitely advocate guide extension catheters when necessary. The one difference with the lithotripsy balloon is that it can be a little bit bulky, so you want to make sure it gets to where it needs to go. It can then be sized 1-to-1. You deliver your ultrasound waves, again, at a low pressure inflation. And here you have the final result. So again, a 3.5 millimeter drug-eluting stent to the circumflex, a 3.0 millimeter drug-eluting stent to the LAD, non-compliant balloon post-dilated with good expansion guided by IVUS. And you really had a very simple, efficient transradial procedure that was very safe throughout. So some tips and takeaways just in summary. You're able to use your standard workhorse wires with intravascular lithotripsy technology. Very quick setup. It is familiar to the techs, the nurses, and the physicians because really it's just standard wire balloon technology. Really needs to be coupled with intracoronary imaging. You have large diameter balloons, 3.0, 3.5, again, compared to some of the smaller diameters of some of the other technologies out there. I personally advocate liberal use of a guide catheter extension to deliver when necessary. And again, permits fast, efficient transradial multivessel PCI, as in this example, with the same day discharge. So really giving the patient a safe and effective technology in all centers everywhere, whether that you do or do not have surgery on site. Thank you very much. Next up is Dr. Sizemore.
Thanks a lot, Alex. Great case, great outcome, and thanks to Shockwave for allowing me to participate in this important conversation. By way of introduction, my name is Clay Sizemore. I'm an interventional cardiologist. I'm part of our Archibald Medical Center, which is a 4-hospital, 3-nursing home health system that has 540 total beds, of which 264 make up our flagship hospital here in Thomasville. Cardiology department does not have on-site surgical backup, as Alex mentioned. We do have an active and collegial backup agreement with the next closest surgical site, which is Tallahassee, Florida. And they're about 45 minutes south of us, just across the state line. So I would like to start by kind of contextualizing the conversation with a case. This is a 70-year-old obese white female that I have known since 2012, at which time I met her during a prior admission, and she had a successful PCI to the mid-LAD and has done well since then. As you can see in the angiogram, she has a very large dominant right coronary artery. There is a critical ostial stenosis. And incidentally, prior to injection, you can appreciate fairly significant calcification throughout the mid to distal vessel. So it's not lost on this panel and participants that there are a variety of methods of managing calcium in the cath lab. We did make the active decision at Archibald among providers and administrators that it would probably not be right for us to bring in devices that would require specific off-label utilization. So we were relegated primarily to angioplasty with either standard balloons or some of the specialty balloons. And this is significant in that we would have to avoid cases with calcium for fear of incomplete dilatation, which would either result in complete inability to deploy a stent or an underexpanded stent, which we all know has now been very clearly associated with suboptimal long-term outcomes. So it was our standard practice to essentially transfer any acute cases, and have either our providers that had privileges down there or colleagues at the other institution perform those cases, which represented an inconvenience to not only the patient, but to the provider. The other thing to highlight here is that we, as a kind of intermediate volume hospital, we are very much committed to a complication avoidance strategy. And it was not lost on us that the complication rates with aggressive calcium modification with atherectomy technologies has historically been associated with significantly more potentially catastrophic complications like severe dissections or perforations. The beauty of IVL, though, is that we not only do we add the ability to perform cases safely, but also effectively. As Alex pointed out, there's robust data sets suggesting that IVL is effective not only in eccentric disease, but concentric disease, and in both nodular and non-nodular calciums. Another important point to possibly centers with lower volumes or new operators, the fact there really is no learning curve. And this is not surprising if you think about the fact that IVL is essentially, from a procedural standpoint, a standard angioplasty. The last thing I would like to point out is I did intentionally choose to present a female patient because we have for a long time known that women in general suffered from higher periprocedural complications and worse outcomes than men. And this was particularly true in the heavy, high-risk calcium subsets, whether it be treated with rotational atherectomy or orbital atherectomy. And you can just see some of the graphical representation of those data sets here. Fortunately, in the subsequent analysis of disrupt data sets, we were excited to see that there was no such sex-related difference. Women had a similarly very low complication rate as did the men in the trial, and so again, super important to us to be able to have a technology that can treat all subsets of morphology. So back to the case, and we'll wrap up. For time's sake, you can see we, like Alex, are firm believers in imaging strategy. This was a case in which we did IVUS, not surprisingly, near concentric calcium at the lesion, and even down into the more normalized distal reference segment of the vessel. Really just a concerning case with regard to potential for inadequate expansion and or complications, despite a heavy load of calcified vessels. The critical nature of the lesion did prompt us to do a gentle pre-dilatation with the 2.5 balloon, which you see in the right frame, which allowed for deployment of an appropriately sized Shockwave 4mm lithotripsy balloon. We unloaded all the pulses in that heavily calcified proximal and ostial segment of the right coronary artery, and ultimately were able to deploy a 4mm drug-eluting stent with excellent angiographic and intravascular imaging results. Kind of just to wrap things up, the Archibald algorithm is, again, imaging driven. If you have any of the criteria listed, greater than 180-degree arc of calcium, greater than 5 millimeters thick or 5 millimeters long, we tend to default to IVL. If you don't have any of those higher risk calcific findings, then we're generally testing with a non-compliant balloon with a quick transition to IVL for any evidence of non-dilatation. And then finally, non-cross lesions remain a challenge for us in the non-surgical center. New Sky document may inform this somewhat, and I wouldn't be surprised if we do for limited no-cross lesions or in cases of extreme calcification that we think by imaging would benefit from a combined therapy. I suspect that we may be introducing those technologies. So again, this is back to our slide, and importantly for us in the post-IVL era, we have got options for not only safety but efficacy, and it really has essentially limited our incidence of transfer to cases that are either surgical or no cross type lesions. So it's been majorly impactful for our patients and our providers, and has been a game changer for us. So With that, I'm going to turn it over actually to my good friend and one of our administrators, Chris Newman, to talk about some of the administrative impacts and hospital impacts of bringing IVL to Thomasville. Thanks a lot.
All right. Thank you, Dr. Sizemore. We appreciate what you do for our patients. Again, my name is Chris Newman, Vice President of Clinical Services at Archbold Medical Center. So for me, this part of the presentation, I'm going to talk about the kind of overarching concept of implementation of new technology in a community hospital setting, especially given the nature that we don't have cardiac backup. The introduction of Shockwave for us is something that is really easy to talk about for us because it really was a hands-on partnership with Shockwave, our providers, and our staff. Shockwave was requested from our physicians, our cardiologists, and we go through a clinical quality evaluation process to look at kind of the concept, understand the costs, and then look at just justification, making sure that it makes sense for us. The Shockwave team was involved throughout this kind of channel of events that took place. And we knew based on the cardiologist's feedback that this technology really would improve their capabilities, our ability to keep patients and care for them in our setting, and then also limit the number of transfers out, which are obviously have a benefit. So obviously from an administrative standpoint, there are always leading edge technologies, but have the payers caught up with it? And so we really are conscientious about doing pre-work to understand what is the reimbursement model. And then we also have an important step to do post-analysis of these cases to make sure that what we thought was going to happen was actually going to happen. So as you can see here, Shockwave Coronary IVL has established a reimbursement pathway in the outpatient and inpatient setting via transitional pass-through payment and new technology add-on. When we implemented, we also were looking at vascular interventional as well. So we were making sure to validate the reimbursement model in both scenarios. So fortunately, every case that we reviewed, we've been able to validate, obviously, what Shockwave had presented to us, and it's been a very smooth process. So for us, really, we look at kind of three tiered approach to this. You know, it reduces patient transfers, it expands our referral base. Again, we have as Dr. Sizemore mentioned, there's certain patients with lesions that we had difficulty with in the past. So either we were deferring them to our referral center in Tallahassee, or we were having to deal with these patients in some other way, which we didn't or don't like to do. We like to be comfortable with the patients we accept. We like to have continue that continuity of care with those patients. And so Shockwave really has improved that. Again, another aspect of this is patient satisfaction. So our community really relies us on as a provider and a steward of their resources. So patient satisfaction always is part of that consideration. Less transfers, less distance from their comfort zone when it comes to treating these lesions. Again, I just want to reiterate, I've said this a couple of times, but there is a peripheral application for Shockwave M5 Plus and Shockwave S4 product. For the community hospital setting, we have 5 labs, 2 interventional radiology, 3 interventional cardiology with a shared staff. So again, the ability to have consistency with a vendor, consistency with ordering. And so that's an important part to how we try and make vendor decisions. And again, that clinical quality committee really has a focus on making sure we don't have kind of dead end items sitting on the shelf. So again, that's just a bonus for us to make sure that we're able to take care of these patients. And our staff, obviously, from a training perspective, they have a comfort level. If they're on call, they have a comfort level with the technology, whichever type of case they're called in for. So that's an added bonus. With that, I'd just like to say thank you. Thank you to Shockwave for the opportunity to kind of share this success with this community and the opportunity to be a part of this. I'll pass this back over to Dr. Truesdale, who will kind of wrap it up from there. Thank you.
Great. Well, thank you everyone so much. It was really just a fantastic round of talks, and I think that set us up great for a fantastic follow-on roundtable discussion, and then ultimately an audience Q&A. I'll start off with you, Dr. Sizemore. I just wanted to get a sense, I think you touched on this a little bit, but what role IVL plays now in your algorithm and how that may have been different from your calcium modification algorithm just a couple years ago.
Yeah, so we have, I think, I'm sure as all of you have, continued to adopt the imaging as a default. That has really kind of driven the algorithm for us most recently. And so we will generally try and do IVUS OCT on every case that we can, and distribution pattern severity of the calcium is kind of what dictates whether we do IVL or test with a non-compliant balloon first. So I would say, the imaging is sort of kind of the driver there, with kind of standard descriptors for calcium severity, kind of helping us with that decision making.
And what about yourself, Dr. Velagapudi?
Yeah, sure. I usually, if I can pass my imaging catheter or a balloon to dilate my lesion, and I notice that there's a lot of calcium, more than 180-degree arc, or, obviously I use IVUS more, but if it was a really calcified lesion, I start off directly with IVL. And then the other important thing is that on my imaging, how big the lumen is. So if there is let's say, a bigger lumen, then I know that my atherectomy devices probably are not going to be that necessary, right? And so then IVL is my go-to there. But most of my cases with calcium these days, I start off with the IVL if I can pass the balloon.
Yeah, those are great points. I think it really echoes a lot in my own experience. And I think similar to what you guys said, I'm big on imaging. And I think the number of people imaging is really increasing significantly. So if the imaging catheter won't cross, that's already your clue. And then you get different algorithms for, balloon. Once you identify calcium, if it's, there's not enough of a channel that you're going to get IVL through, then, I would start off with a compliant balloon to see if I can use it to deliver, and a guide extension catheter. But there still are instances where, I might need to do, roto-orbital, really just to create a pilot channel. But the follow-on ability to take a 4.0 balloon and size that 1-to-1 really is a game changer. Following on to that, Dr. Sizemore, I wonder if you could make a comment on your feeling of safety, which, and actually I want to hear from Mr. Newman as well, because we're all concerned in safety, but I think it's different when you don't necessarily have the immediate pass off to the OR or ECMO or whatever the case may be, and maybe you don't have a center 5 minutes down the road. So I kind of wanted to get your thoughts, Clay, first.
Yeah, I think it's one of those things. Whenever we recruit a new partner, there's always an extended conversation. Well, especially a new grad or a new fellow, well, who am I going to call in the middle of the night when things go sideways? And so that's why, even with the update, if we bring in some atherectomy devices, given a choice between two, where one is, likely to be a little bit safer, I think, being at a non-backup center, I'm going to choose the safest possible option, especially knowing that it's broadly applicable in lots of morphology. So I think the safety benefits there by having an on-label option, a safe option, are just huge for the hospital. Do you agree with that, Chris?
Yeah, I mean, two things. One is your earlier question about your pathway and your algorithm. When you start saying we have a kitchen sink lesion, that the administrator and me instantly starts seeing the supply charge well exceed the reimbursement. So it's comforting to know that we have a first line option that leads to successful intervention in these calcified lesions. So that's the other fear from an administrative standpoint, is obviously safety. What's the comfort level of the providers when we're recruiting providers? What's their comfort level? Are they going to get enough professional satisfaction out of taking care of our patients is one part of it. And then, we don't want that person who's a real cowboy. So making sure that we have that balance is key to that. And then the other thing I think that's important, my biggest fear is that we invest in technology that's a flash in the pan. So we want to make sure we're validating something that kind of is we expect to have an extended period of validity and use.
Yeah, it's a really fantastic administrative perspective too. I want to kind of turn over to you, Dr. Velagapudi. What are some key takeaways if you had to really distill it down to basic for case selection between surgery on site, non-surgery on site, and also how that may break out into the ASC OBL and where you think the value of intravascular lithotripsy lies in that decision making for treating patients?
Yeah, I think it's really important to reiterate the data that I had just presented, both in the US as well as outside US. The complexity of the lesions have increased. We are seeing more of the calcified lesions in all our PCIs. And there's been data, there's only 2 randomized trials, but there's data all across a lot of outside US countries as well. For example, UK has data on left mains. Their PCIs, about 40% of their left mains were done at centers without surgical backup, right? And their outcomes were no different when compared to the outcomes at surgical centers. So we're seeing that all these are being done in a safe manner with low complication rates. So when we're selecting patients, I think the first question is the lesion and patient complexity. We have to look at those and make a decision whether this complex patient has comorbidities that would need high, support. If they have a complication, are they going to be able to tolerate it? It's a patient with LVEF of 20% is way different than somebody with 50%, right? Even if you're fixing the last remaining vessel, the patient with a 20% EF is not going to do that great. So I think once you figure out that the patients, whether or not are super complex and need a cardiac surgery facility, I think that's the first step. And then you look at your lesion complexity and say, okay, am I able to treat this in safely without complication, or is there going to be a complication? So once you figure that out, I think we did nicely give a list of things that should not be done at ASCs or OBLs or level 1. That's because they only have a balloon pump available. You can't put them on a PVAD. And so it's just not safe to do or do cases like left main or severe complex calcified lesion or grafts and things like that. So it's really important that you keep that in mind when picking where you can do. So I think just with regards to ASC and OBLs, I will tell you that there is some data that shows only about 0.9% of the cases were being done in these facilities. But there is a predictive data from being research group that says about 33% will be done in the next few years in a facility without surgical backup. So I think the most important thing as operators is we have to be ready for what's coming. And I think that really figuring that the demarcation between which lesions to be done in the level 1 and ASCs and OBLs is really important. And I think IVL, as we all just discussed, big game changer with such low complication rates and high success rates that you could use it at all facilities. And it'll be interesting to see actual data, prospective data from these centers as to what kind of lesions are we treating and what the outcomes are going to be. And I think that's going to be a big game changer.
I wanted to go back to something really, really important. I think that both you, Clay, and you, Chris, talked about. You talked about your community. And I think about the joke, like if I go to a four corner area in Boston, if I don't like one hospital, I can cross the street, go to another. If you're in a community where that is not the option, you really owe it to your patients to not make them travel 200 miles, leave their families, not be close to their families, not be close to their children. What I'd kind of like to dig in deeper is in your experience so far, IVL in your community, have What have you seen and noticed, and how is that you have felt that as providers, as administrators, and from, seeing from the patient perspective?
So super impactful. I think people underestimate the complexity of particularly now in a COVID, post-COVID era, when all the hospitals are full and the bed availability is essentially none. And I can't imagine doing the level of transfers that we did just 5 or 6 years ago. Now it wouldn't work. People would just sit and wait, and it would just be a disaster. So miraculously, timing couldn't be better. But even beyond not being able to physically get approval from our backup hospital to come and do a case like I used to. The cost of the ambulance ride, the duplication of nursing services, we live in a rural community where the patients are lucky to have transportation. Imagine the families then having to drive into, quote unquote, the big city, with the big center where the parking is terrible and most of them are immobile. It's just, you can imagine the litany of complexities and complications that goes along with it. So when we have polled the audience in terms of patients and the community in general, as we've kept more and more patients in Thomasville, the overwhelming response has been, thank goodness. So, Chris, has that been your experience as well?
Yeah, two things. I mean, you kind of struck a chord also with this safety conversation in a community setting. If you're pushing the envelope on safety and you have one bad outcome, it's hard to keep that in a bottle in a small town. So I think that's an important part of this adoption of technology. And then secondly, I'm sure everybody can speak to this from a hospital margin perspective. We're operating on less and less. And so trying to find those opportunities to increase volumes with the same patient population. This is one of those opportunities for us that has yielded, I can get under Dr. Sizemore's skin quickly if I say, I want you to be busier. And for him to really want to be busier and manage his patients. This is a technology that can accomplish that.
I think kind of for our final discussion point to that last point with you, Chris. So I know whenever I'm saying, hey, there's this new whiz bang device, I want it, like, this is great, but you're really looking at it appropriately at a much larger perspective. So I think we've established all the benefits to patients, to the community, to safety, but there's the real world. So from a purely financial perspective, what has been your experience in terms of bringing the technology? Cost neutral, cost saver, cost winner?
Yeah, again, there's no magic bullet here because the variety of payers, the complicating nature, the increasing complicating nature of each payer, the regionality of reimbursement is also increasing daily. So I think I mentioned earlier, you can do your due diligence, but really this retrospective, keeping your finger on the pulse of the retrospective aspect of reimbursement and looking at it from a holistic perspective is really the key to it. We continue to see this being a winner for us. Again, I think it's those cases that historically were multiple catheters, multiple attempts, where we have degradation of margin, and we're seeing that being less of the case. So I think that's the takeaway here is due diligence retrospectively to make sure that you're meeting that need, and I think you'll see it as a success.
This was a fantastic set of presentations and roundtable discussion, and I'm really excited to move on to the question and answer session from the audience now. So just as expected, have a lot of questions that have already come in. Please keep them coming. Before we start, there have been some reimbursement questions. So I think we're going to stick to clinical things here in the chat, but you will receive a follow-up email after the webinar, and the folks from the Shockwave team can engage with you on those questions. So we really just have a little bit under 10 minutes, so let's get moving. So let me start with kind of you, Clay and Chris, as a team answer here. So if I'm a physician working in a non-surgical facility and I'm interested in getting intravascular lithotripsy on the shelf and incorporating my program, and I don't know where to begin. So, how would you say, how do you bring that into the facility, and where do you plug that into your, your practice?
Sure. So I think that, I think that what I would say right off the bat is trying to really partner with your administrators is to your benefit. Having an active dyad type model like we have with Chris and myself and the other administrators and the other clinical leaders is super important. So, we tend to, when a new technology like this comes along, we kind of try and assess the need and make a pitch from a clinical standpoint. But I will have to say, I'll turn this mostly over to Chris, because they have a committee process where they really vet all versions of devices and technologies from a standpoint of both effectiveness and cost. So Chris, why don't you kind of round out that answer?
Yeah, sure. So that structure is important. So setting the physicians up with an expectation, they're typically who are bringing these ideas forward. And they have an expectation that they know we meet monthly. But if there's a need for ad hoc, we obviously can expedite a decision if there's a specific patient, a specific need. So really tailoring that to a consistent expectation has been our recipe for success. Getting them comfortable with no by being transparent about the result of our analysis. And then after the fact, I've mentioned this a couple of times, but coming to them after the fact and showing them the real data of true patient scenarios. I know one of the questions was about denials, the increase in the number of retrospective and after the case denials, and really feeding that information back to your team and putting clinical people on the front end of that to make sure you have the data to support the case is important. So, it's a team effort. It's never ending and it's only getting more complicated.
Alex, I would just add to that. I think the other thing is we've got to all kind of encourage our administrators to look at big picture and not just focus on, one given procedure. If you have to look at, resource utilization across the entire procedure. As Chris alluded to earlier, are you using fewer balloons? Is the, patients getting out with, over the course of a year with fewer complications because complications are so expensive. So I think you as the provider, it's incumbent on us to kind of make the whole case.
Now, those are great points. And the last one, I think, could take up an hour on its own. I think we all sometimes get caught up in episodes of care rather than the life of the patient, and whether that's talking about calcium modification technologies, whether that's talking about intravascular imaging. I think there's a lot of these tools that we got to think about how to provide better longevity to our interventions to patients who hopefully will have many, many decades to live. So I want to send this next question to Poonam. This was one that came in through the Q&A. The exact question was, does the documentation need to state the calcium severity, and it is a % of value to do this? Is there a certain % that you should have before you use intravascular lithotripsy? I think this is probably, getting at what are some of the deciding factors, presumably, by intracoronary imaging, to help you decide, for or against any calcium modification, or maybe specifically intravascular lithotripsy. So maybe I could get your thoughts, Dr. Velagapudi.
Sure. We use imaging in all our cases, and the three important things: if the arc of calcium is more than 180 degrees, or if the length of the calcium is more than 5 millimeters, or the thickness is more than 0.5. I mean, if you don't see any of those, then I think you can safely say, okay, I can use an NC balloon, and then stent and then go from there. Or if the NC balloon doesn't work, then you kind of are thinking about, calcium modification techniques. But if I see any of these on the imaging, then I know for sure that probably some sort of calcium modification would probably be useful. And at that point, we know if the wire goes and balloon goes, then probably IVL would be a good option. Whereas if you can't pass a balloon and you just have to, your wire crosses, but balloon does not cross, then probably an atherectomy device would be a good way to go. Again, the other thing is that calcium nodules, I don't think the Shockwave, we may need some sort of an atherectomy in those situations to shave off the nodule. And then for the deep calcium, we know that IVL probably is a good option. So I think we can start off with the imaging first and then go down that algorithm. And then in the documentation per se, we usually, we write if you're using IVIS and if there's anything specifically that we see, but I'm not, really following any guideline specific, documentation. It's the same as my other procedures as to why we're using an atherectomy, kind of like explaining yourself, or like what the thought process was is what I document usually.
That's great. That's very helpful. I'm going to move on to another question just because I know we're kind of short on time. So Chris, I just wanted to ask you a little bit about, your retrospective center analysis regarding reimbursement. How did you do this and what did you kind of discover in this process?
Yeah, it's an ongoing challenge, but it's really that, we're looking for what are the reasons for denials, what are the insurance companies really focusing on, and then making sure that that's part of the upfront process. So that feedback mechanism really is the important aspect of it. There's the authorization process used to be kind of a checkbox process, but the authorization is adding more and more clinical expertise to make sure the medical necessity is covered, and we're covering all of our bases. So that's really the part that we're focusing on to make sure that we're taking care of that up front. And we're not battling that. Obviously, it takes a lot more time on the back end than it does doing it on the front end.
Great. No, thank you very much. And here, I know one other quick question. It's a balloon. This is a balloon and catheter, but I think the technology differs a little bit from some other balloon catheters. And I wanted to hear from Poonam, what are some of your common troubleshooting tips for someone new to the technology? For me, I think about deliverability. It's a little bit stiffer. So I think about guide extension catheters and combining with the imaging, but I kind of wanted to get your thoughts and your opinions on troubleshooting specific to this technology.
Yeah, sure. I think it kind of applies to what we see with our NC balloons or stents, right? Like it's just about deliverability. It's a little bit harder to deliver these balloons, and we don't have the OPN, but I've heard that the OPN balloons may be a little easier to deliver as compared to this, but I cannot comment on that because I haven't used the OPNs. But it's the same thing, use a guide liner or, try using another smaller, maybe another NC balloon to open up a little bit, or use a buddy wire to help, and things like that. So I think that the same strategies we use for NC balloons are what I apply for this. One other thing that I never go beyond the 4 millimeter, I go up to 4 and I don't really go up to 6 when I inflate these balloons for delivering the shock. And also between the runs, it's important to actually de-air because the shocks are delivered. You have it produces the air within the balloon, so you kind of de-air in between when you see that, and then prep the balloon again before you deliver the shock. So those are some things that I just wanted to mention.
I think, thank you very much. And I think, sorry to rush along. I think we have time for very last question comment. So this is again for Clay and Chris. How is, your referral center benefited from, the use of intravascular lithotripsy regarding patient transfers and things of that nature?
So I think it's funny. We when we launched fairly early, and with the help of IVL, produced some stuff that was put out on social media and some other things, and we immediately got patient kind of directly calling and setting up appointments because they had done a calcium, a CT calcium score, or some CT scan had showed some calcium, and they were kind of, our patients are progressively more in tune to kind of some of this stuff. So I know we picked up a bunch of patients in that regard. The other thing is that living in a rural community, we have rural physicians and small practices that are referring to us, and they're very committed to the idea of keeping patients local, because they know they get better communication from the folks that they go to dinner with and church with and interact with in their communities. So I think the feedback overall has been overwhelmingly positive from the patients and the referring doctors.
Fantastic. I'm really sorry that we're out of time, because I think we could all go on over for a long, long time. But I want to thank all of my co-panelists here today for their time. I want to thank the audience for all the questions that were shared. Tomorrow, Cardiovascular Business will be emailing everyone a link to the webinar to watch again, share with a colleague. It's also going to have links to Shockwave resources such as reimbursement, so you can have your questions answered afterwards. And I'll just finish with thanks to everyone, and have a great remainder of the day.